morning and welcome everybody to this session. This session is going to be about prevention and treatment of thrombotic and non-thrombotic APS. I'm Dr. Constanza Danielsen and I'm co-chairing this session with Dr. Beatriz Grant, and we want to give you a very warm welcome today. We'll be presenting our first speaker. It's going to be Dr. Silvia Foddai. Silvia Foddai is Doctor of Medicine at the University of Torino. Welcome, Doctor. You can start whenever you want.
Can you hear me? Yes, okay. So the topic that was assigned to me and for which I want to thank the Congress Committee is the influence of cardiovascular risk control in thrombotic APS, evidence or common sense. So I know that among us there are important experts who contribute to the development and the writing of cardiovascular risk assessment in APS and can navigate this very intriguing but intricate topic. So I want to start my speech with a clinical case. So our patients that we currently have in our clinic, in our department, that is giving me a little bit of concern. She's a 42 years old woman. She's called LOD, and she is suffering from SILE. In the last 10 years, she's got 3 different renal flares, and she was treated with different type of drugs, starting from cyclosporine to azathioprine, cyclophosphamide, rituximab, and mycophenolate mofetil. Moreover, 3 years ago, she's experienced a DVT that was after complicated with a pulmonary embolism. We found her to be positive for cardiolipin antibodies of IgG isotype at high titer and lupus anticoagulant. So an additional diagnosis of APS was made. Moreover, she's frankly obese. She's got hypertension and hyperlipemia, and she smokes. So recently, during follow-up procedures, we found out that she's got a proteinuria of 7.8 gram and a high titer of anti-DS DNA antibodies. Her complement level are normal, and as her whole blood cells count. So we, of course, consult with her, and we proposed her to do a renal biopsy in order to assess in a better way what was the kidney function and the kidney situation. However, she very strongly refused the procedure because that will be the fourth procedure for her. So what should we do in this patient? How should we approach her? When we think about cardiovascular risk in APS, we have to imagine three-dimensional, self-powered vicious circuits in which every element is able to influence and enhance the others. And keeping that in mind, we can all understand the big elephant in the room, which is the still high burden of recurrences and thrombotic events in APS, even though we are treating our patients. So assessing the cardiovascular risk in our patients is still important because we still got a high mortality. But I believe it's important to start from the basics, so the assessment of traditional cardiovascular risk factors. In APS, we've got a different percentage of traditional cardiovascular risk factor among our population, and it is because it depends on the type of population that we are taking into account. However, what we know is that at least one traditional cardiovascular risk factor is present in our population. But that's a good news because we can work with them and when we can implement them. Going a little bit deeper in APS and the cardiovascular risk related to APL presence, I propose to you different type of mechanism through which APL participate in the development of cardiovascular risk. First of all, endothelial dysfunction, then accelerated atherosclerosis, microvascular involvement, APL profile, extra criteria, clinical manifestations, and medications. When we think about endothelial dysfunction in APS, we don't have just to think about the most paradigmatical way through which APS exert its features, which is thrombosis. But through endothelial dysfunction, APL can exert even the process of atherosclerosis and the process of vasculopathy. Of course, this is exerted through an intricate pathway in which there are different actors, such as endothelial cell activation, platelet activation, and as brilliantly described in the previous days by Professor Zuo and Professor Chari Lopez Pedrera, by monocyte and neutrophilic activation. Accelerated atherosclerosis. Right now, we know that patients with APS have a high burden of atherosclerosis. There are different points of view on the fact that we might or might not have subclinical atherosclerosis in APS, so a level of atherosclerosis that we can find where it is incipient, but where we can still work and we can reduce or eliminate the development of future atherosclerosis. What we know is that there are different pathways through which atherosclerosis could be exerted in APS, and two of them are represented here by two works of Lopez Pedrera and her collaborative group, and Benajano and his group, which are the correlation between APL and oxidized low-density lipoprotein or activation on lymphocyte T, which exert and pronounce the atherosclerosis development. So we know that the risk of atherosclerosis in APS is high, and is as high as in diseases that are known very well to be associated with atherosclerosis, such as diabetes. Moreover, it's easy to understand that secondary APS have a more overt manifestation of atherosclerosis, and that's because we've got a more utilization of proatherogenic drugs such as steroids. I want to address microvascular involvement in APS because it's important due to the fact that could be the first clinical manifestation that we can have in our patient, and sometimes is or underdiagnosed or misdiagnosed. And to name two of the way in which microvascular involvement is manifested, I want to point out livedo reticularis and acute myocardial infarction. In the first case, livedo reticularis could be the first type of presentation that we have in our patients, but we don't have to dismiss it because it could underline the presence of microvascular involvement. When it comes to myocardial infarction, we have to know that APS patient might have normal coronary arteriography, but they can have a microvascular involvement which determines the development of a myocardial infarction. And moreover, due to the myocardial involvement, we can have a dysfunction in the ventricle, and so the best way to assess whether or not we've got microvascular involvement in APS is through the determination of microvascular involvement using an MRA, a cardiac MRA. At last, we have to assess for the presence of APL, of course, because the more is the number of APL, the higher is the risk for thrombosis and recurrences. And we have, of course, to assess, but in this day we stress this a lot, for the presence for extra criteria antibodies, so APS-PT and anti-domain 1. we have to assess for the presence of extra criteria clinical manifestations. We'd have to be acknowledged because they've got a high impact on cardiovascular assessment in APS. To name two of them, we've got valvular heart disease and pulmonary hypertension. In the end, we have to assess for the presence of drugs that can impact on the pro-atherogenic, that can impact on the whole cardiovascular risk assessment, such as steroids. But what are our tools? How can we understand which patients it's at higher risk and which patients is at a lower risk? So what we know right now is that the normal cardiovascular risk assessment tool, the ones that were prepared and thought for the normal populations, tend to underestimate the risk in APS. So we try to assess the risk using two different tools, which are the GAPS and the Q-risk that was recently developed in a way to assess the risk in SLE patient with or without APL. But what we found with a recent work was that, however, even though GAPS was not prepared and was not thought to consider the whole cardiovascular risk in APS, however, still represent the best tool that we can have and we can use in a handy way to understand whether or not our patients is at a higher risk for developing thrombosis and recurrences. Of course, we can have the help of investigations, normal investigations, such as echocardiography or intimal medial thickness evaluation or flow-mediated dilatations. Of course, all these investigations are very, very useful, but sometimes they could be tricky due to a big problem, which is still the reproducibility issue. So these investigations works, but they have to be done by very practical clinicians. And there could be very important differences from one center to the other, from one doctor to the other when they are assessed. But they are still handy, very handy. In the end, what are our tools? Like, what are our weapons when we confront the cardiovascular risk in APS? I here put a little cartoon which is a little bit intricate, but wants to sum up one thought that I have, which is we can use our treatment to treat the patients for a precise purpose, but we can have such as a thing that I call a lateral effect. So something that is still happening, but that's not the reason why we are doing or we are prescribing that drugs to the patients, that help us diminishing the atherosclerotic risk in our patients. To name one, hydroxychloroquine that we use in APS patients because it has an antithrombotic effect, but of course we know that it also has an anti-inflammatory and an immunomodulatory effect. To name another one, which is starting to be used in APS, which is belimumab, we know that, of course, it lowered the number of APL, and doing so, it exerts an anti-atherogenic effect by inhibiting endothelial cells dysfunction. Moving on, but going back to the start, what are the evidence and what is the common sense that can help us through the cardiovascular risk assessment and treatment in APS? So when we think about cardiovascular risk factors, the common sense tells us to control them, okay? To console the patient so much that they will be at our side and they will do what we are proposing them to do. But the evidence so far are not present. However, we know by a recent work by Jelnik that counseling very hard the patients, determine an amelioration in traditional cardiovascular risk factors in a cohort of SILE patients. So it's easy to think that this could be transferred even to APS. When we go to treatment, the common sense, as I showed you before with the cartoon, is that through the utilization of immunomodulation and immunosuppression, we could reduce the cardiovascular risk. And evidence, as I previously showed you, are still, however, preliminary. When it comes to recurrence, if we have done our job well, they should be, as common sense suggests, reduced and prevented. And the evidence could help us because if we are using a scoring risk, the score would be lowered. When it comes to acquiral damage, again, if we have done our work well, it should be prevented or it should be reduced. And an evidence is to use the DIAP score, which tells us how much is the acquiral damage. And in the end, the APS-related cardiovascular risk factor should be reduced if we have done everything correctly, and what we can use to understand if they are correctly reduced is to assess the reducing through the utilization of APS activity index, which is currently under preparation by a task force of the EULAR. So we go back to the start. How we treat our patient. As a recommendation on lupus nephritis treatment, we proposed her to add belimumab with intravenous infusion. Moreover, we counseled her to perform dietological counseling, to stop, of course, smoking, and to perform a patient-to-patient meeting group, because in these patients, it's pretty obvious that we've got a big problem of compliance. So what are the unmet needs? First of all, we have to have a schedule of the exam that we need to perform and how often we need to perform them to assess correctly the risk. So we have to implement the guidelines on how and when to perform what. In this slide, I show you and I underline that it could be useful sometimes maybe to start to think about performing cardiac MRI in young patients in order to detect an early microvascular involvement. Then new biomarkers, of course, we need them to understand and to discriminate patients that could be at higher risk for cardiovascular events and cardiovascular risk as a whole. Risk assessment tool, of course, regarding the techniques that we use, so echocardiography or angiography. And in the end, implement the compliance, which is something that sometimes we don't think so much as clinicians. Is a topic that we try to dismiss a little bit, but if the patient is not with us, is not working with us, everything that we can do is completely unuseful in the end. So a nice thing that I found out in the literature is that using app could enhance the compliance very much. And in the end, maybe we should start to think about a more robust approach at the beginning of the treatment of the patients in order to reduce at the beginning the risk. So in conclusion, cardiovascular risk in APS is high, really high per se, and these are results of multiple factors that need to be acknowledged in order to assess correctly which is the high or which is the level of risk in our patients. What we need right now is to implement the reproducibility among the exam that we are performing in order to assess the risk, and that a correct baseline and a thorough follow-up need to be set and carried on in order to have a patient that is with us and follows our counsel. Moreover, when we can, it should be nice to tailor the approach for the patients and to identify a more treatment that is made up and thought for him or for her. Of course, we need further research to identify specific screening program and to individuate novel biomarkers predictive of future cardiovascular events. And with this, I'm finished. Thank you very much.